Dear student, in this video we are going to discuss about the lung volumes and capacities. At the end of this session, we'll be able to define lung volumes and capacities, and we'll be able to give their normal values. You'll be able to explain the methods of measurement of the volumes. We'll be able to elucidate the forced vital capacity. We'll be able to differentiate between obstructive and restrictive lung diseases. So this is a spirogram that is showing different lung volumes and capacities. There are 4 lung volumes and capacities. We can see here the TV or the tidal volume, inspiratory reserve volume or IRV, expiratory reserve volume or ERV, and the residual volume. These are the 4 lung volumes. Then we have 4 capacities: inspiratory capacity, residual capacities, and the vital capacities, and the total lung capacity. So these are the 4 capacities. Now come to one by one. First is the tidal volume. Tidal volume is the volume of gas inspired or expired during quiet breathing. So these 3 points are important. Volume of gas inspired or expired when during quiet breathing. What is the normal value of it? It is around 500 ml in adults. Now, if I ask the subject to don't take the quiet breathing, take the forceful inspiration and give the forceful expiration. So, we will get the inspiratory and expiratory reserve volume. Okay, so the amount of air above the tidal volume, the extra amount that I am inhaling is will be the inspiratory reserve volume. The amount that is I am exhaling, my maximum expiratory effort below the tidal volume, that is the expiratory reserve volume. Regarding definition, we can say that inspiratory reserve volume is the amount of air inspired with a maximal inspiratory effort in excess of normal tidal volume. So in excess of normal tidal volume is important term, and the normal inspiratory reserve volume is 3.3 liter in case of men and 1.9 liter in case of female. Now come to the expiratory reserve volume. The volume of air that can be expired with maximum expiratory effort. So this term is important after the normal tidal volume or expiration. So these two terms are important. So one is a maximum effort, and that is after the tidal volume. This is known as expiratory reserve volume. The normal value of expiratory reserve volume is 1.2 liter in male and 0.7 liter in women. So now come to the third volume, that is the residual volume. Even after forceful expiration, some amount of air will remain inside the lung. So that is denoted as the residual volume. The volume of air left in the lungs at the end of maximal expiratory effort is the residual volume. The normal value of residual volume in men is 1.2 liter and in women it is 1.1 liter. So this is about the volumes. So in this picture we can see that the central portion, that is blue area, is the tidal volume 0.5 liter or 500 ml, and the above it, excess of it, is the inspiratory reserve volume, that is 3 liter, and below it is the 1 liter, that is inspiratory reserve volume, and even after maximum expiration the amount remains in the lung is the residual volume, that is around 1.2 liter. Now come to the capacities. So first come to the vital capacity. The maximum volume capacity is nothing but the addition or summation of different volumes. So vital capacity we get if we add the tidal volume, the inspiratory reserve volume, and the expiratory reserve volume. So the maximum volume of air that can be expired after a maximum inspiratory effort is called the vital capacity. The normal value of vital capacity in men is 4 liter and in women it is about 3 liter. Then come to the next capacity, that is the functional residual capacity. We get the functional residual capacity by adding the residual volume and the expiratory reserve volume. So by definition, this is the volume of air remaining in the lungs at the end of each tidal expiration, and this is the sum of expiratory reserve volume and the residual volume, and its normal value is around 2.2 to 2.5 liter. Another capacity is there, that is the inspiratory capacity. It is the maximum volume of air that can be inspired after tidal expiration. So tidal volume plus inspiratory reserve volume, this sum is known as the inspiratory capacity, and the normal value, it is around 3.5 liter. And if we add all the lung volumes, we will get the total lung capacity. By definition, we can say the volume of air present in the lungs at the end of maximum inspiration, that is known as the total lung capacity. Its normal value in men is about 6 liter, and in female it is around 4.2 liters. So it is all about our 4 lung volumes, that is tidal volume, inspiratory reserve volume, expiratory reserve volume, residual volume, and 4 capacities: vital capacity, inspiratory capacity, functional residual capacity, and the total lung capacity. One point I want to highlight here, that is the functional residual capacity it has got some physiological importance. It is important for maintaining a stable gas tension in the lung, so that at all times enough air is available for gaseous exchange along the alveolo-capillary membrane. Okay, due to sudden alteration in gas tension, okay, or due to any interruption of respiration, if it is present, then there will be no reduction of the gaseous exchange because of this reservoir. Okay, so FRC is actually, it maintains the stable gas tension in the lung. Now, how can we measure all these volumes? We can measure all these lung volumes and capacities by the spirometry, except the volume that remains in the lung, that is the residual volume, and the capacities related to it, that is the functional residual capacity and the total lung capacities. Okay, so but I have told you the values of residual volume, that is 1.2 liter, the FRC value, normal value, and the total lung capacity that we know. So how did I get to know about all this? So there must be another method other than spirometry by which we can measure the residual volume. So this is a electronic spirometry now available everywhere, where we do the lung function test and get these lung volumes and capacities. Now residual volume can be measured by gas dilution method. Here we will discuss this method, that is specially helium dilution method, and it can also be measured by body plethysmography. Now helium dilution technique, what we actually do, we actually, a spirometer of known volume is filled with air mixed with helium at a known concentration. Okay, so helium is actually 10% helium in oxygen. This helium oxygen mixture is taken. Okay, so we know the volume of the spirometer, we know the concentration of helium oxygen mixture in it. So we know the V1 and C1. Now I will connect the subject with the spirometer, and I will ask the subject to breathe in. Okay, so when the subject will after the subject rebreathes, so we will know that the helium oxygen mixture, it will equilibrate with the spirometer. So the concentration of the helium oxygen mixture in the spirometer will be equal to the concentration of helium oxygen mixture in the lung. So we know the C2 also. So now we will apply this value to the conservation of mass principle, and we will calculate. One important point is that we can perform this test in two ways. I may ask the subject to exhale quietly and then take the breathing from the spirometer. In that case, I will be going to measure the FRC, or I can ask the subject to exhale forcefully. After that, take the breathing from the spirometer. In that case, I will be getting the value of residual volume. Okay, so we know the C1. C1 is the initial concentration of helium oxygen mixture. We know the V1, that is the volume of spirometer initially. Then we know the C2, that is after rebreathing. So the concentration of helium oxygen mixture in the lung and the spirometer, it will be in equilibrium. So we know the C2, and V1 is the initial volume and V2 is the unknown volume into which the it has been mixed. So our aim is to measure the unknown V2. So V2 will be is equal to V1 into C1 minus C2 divided by C2. So in this way we can measure the FRC or residual volume. As I told you, if the test begins at the end of normal tidal volume, that is end of expiration, then we will measure the FRC. If the test begins at the end of forced vital capacity, so then we will measure the residual volume. So similarly, if the test starts after maximal inspiration, then we are going to measure the total lung capacity. FRC can also be measured by body plethysmography. Now we have measured all these lung volumes and capacities. We want to focus now on the special aspect, that is a vital capacity. We know the definition of vital capacity. So vital capacity, what are the factors that regulate vital capacity? Obviously, it is the body size. The larger the person build, the greater will be the vital capacity. It reaches its maximum around age 20. The more the age, the vital capacity will be less. And gender, on an average, women have lower vital capacity than men. And another point is the fitness. As fitness increases, vital capacity increases. So other than all these factors, one important factor, it is often asked in exam, that is the posture. Posture has a very important role to play in determining the vital capacity. It is seen that in the sitting and standing posture, the vital capacity will be more than in the supine posture. Why it is so? Because while we are sitting or standing, due to gravitational pull, our diaphragm will be pulled much more down. So the vertical diameter of the thoracic cavity will be increased. Whereas on the other hand, when we are in the supine posture, the abdominal viscera will push up, so that will prevent the downward movement of the diaphragm. That is the reason. So there will be less expansion of the thoracic cavity. So in the sitting and standing posture, there will be more vital capacity due to gravitational pull of the diaphragm. This is one point. Second point is that while we are standing or sitting, there is peripheral pooling of blood. Blood is more on our lower side or inferior extremity. So there is less venous return on the right side of the heart. So from the right side, we know the blood is going to the pulmonary capillaries. So pulmonary capillaries, they are surrounding the alveoli. If the pulmonary capillaries are not dilated, they are compressed due to less venous return. So alveoli will get more space to expand. Okay, alveoli will get more space to expand. So this is the reason why there will be more vital capacity in sitting and standing posture. One, because of the downward pull of the diaphragm, which will increase the vertical diameter of the thoracic cavity. Second is there will be less pulmonary congestion due to peripheral pooling of blood and less venous return. Now we want to add, we know about the vital capacity and its definition. Now we want to add one adjective before vital capacity, that is the forced vital capacity. That is, for vital capacity, when we measure in the spirometry, we ask the subject to inhale maximally, then exhale maximally. Now if we ask the subject also to exhale as fast as you can, that means I am incorporating a time factor into it, I will get the forced vital capacity. So the volume of air that can be expired with greatest force and speed, this is important, after a maximal inspiration is the FVC. So FVC differs very little from vital capacity in normal subject, but it is proportionately more reduced when there is airway obstruction or airway trapping. Now, what is the physiological importance of forced vital capacity? The maximum volume of air that can be exhaled after maximum inspiration is VC, or vital capacity. When expiration is performed as rapidly, as forcibly as possible, so the volume is FVC. Okay, but VC measurement is very important because it helps to differentiate between the obstructive and restrictive lung disease. Okay, so from FVC, two other important lung functions are obtained. One is the forced expiratory volume of air exhaled in first second, that is FEV1. 1 stands for first second. Okay, so this FEV1 can be measured from FVC, and the forced expiratory flow, that is FEF 2575, that represents the expiratory flow rate over the middle half of the forced vital capacity, that is between 25 to 75%, that can also be measured from FVC. So why FVC is important? It is important because two other factors can also be measured, which are clinically very important. One is FeV1, that is a forced expiratory volume of air exhaled in first second, and another is the forced expiratory flow FEF 2575. Now, by these values, we can differentiate between the obstructive and restrictive lung diseases. So, obstructive lung disease, we know that there is obstruction in the conduction or conductive zone. Okay, this obstruction may be due to inflammation, due to bronchospasm. Okay, so many factors are there that prevents the entry of air to the alveoli and in the gaseous exchange. So, this is the obstructive lung disease. Okay, so here we can say that, so what happens if there is any obstruction or traffic jam? So it will take more time to reach the lung. Okay, so FeV1, normally we know that the FVC or forced vital capacity is 5 liter, and in the first second, out of this 5 liter, we exhale in the first second the 4 liter. Okay, so FeV1 and FVC ratio, it should be equal to or more than 80%. In the first second, we can exhale more than 80% of the FVC in normal individual. But in case of asthmatic patient, as there is a traffic jam or obstruction, so in the first second the amount will be less. Although at the end of the expiration, the patient will be able to exhale the whole amount, but in the first second FeV1, you can see that it is very much reduced, 1.8 liter instead of 4 liter. So the ratio of FeV1 FVC, so FV1 is very much less as relative to the FVC, so the ratio will become much more less in obstructive lung disease. So how can we differentiate between obstructive and restrictive lung disease? First, what are the types of obstructive disease? It is a bronchiectasis, asthma, bronchitis, emphysema. These are the examples of obstructive lung disease. Whereas when there is any kind of restriction of the lung expansion, it may be due to fibrosis, it may be due to interstitial lung disease, sarcoidosis, or any testual or neuromuscular disease, testual deformity or neuromuscular diseases, where there is no problem in the airway conduction or in the gaseous exchange, where the expansion of lung is defective. So the characteristic of it will be, in case of obstructive lung disease, most importantly, the FeV1 FVC ratio is normal, is below the 80%. But in case of restrictive lung disease, although FeV1 is reduced, FVC is also reduced. So there is proportional reduction of FeV1 and FVC. As a result of that, the ratio will remain normal. And sometimes it is seen that FeV1 is normal, FVC is much more lesser. So the value may be higher in some cases also. Okay, so the obstructive lung disease, there is limitation of airflow due to partial or complete obstruction in the conductive zone. Restrictive lung disease, reduced expansion of the lung parenchyma, and these are the examples. In total lung capacity, in case of obstructive disease, it is normal. The forced vital capacity is also normal, but in restrictive disease, both are reduced. But in case of FeV1 FVC ratio, it is reduced in obstructive, whereas it is normal in case of restrictive lung disease. So from the learning objectives, I think now it is clear. You'll be able to define the volumes and capacities, and you'll be able to give the normal values. You know the methods of measurement of these volumes, simple spirometer and also the helium dilution technique. You'll be able to elucidate the forced vital capacity and why it is physiologically important. You will be able to differentiate between obstructive and restrictive lung diseases. So this is in nutshell all the lung volumes and capacities and their normal values. Thank you.